And I think we should go to our last presentation. And please, Dr. Goldie, continue. Thank you.
Okay. All right, Igor. Thank you so much. So we're really excited, and this is boy, we've had 2 very rich days. So let's see my paper. So we're ready for our keynote address by Dr. Yaakov Stern from Columbia University. And Dr. Stern is going to talk about addressing heterogeneity and disparities in AD, in Alzheimer's disease. So, Dr. Stern.
Thank you very much. It's been a very interesting 2 days. I've been very glad to take part. Some of it's a little over my head, but some of it was really up my alley. I really appreciate your invitation to give this address. I had the honor of speaking to this last meeting of this group on a similar topic, but I think the issue of heterogeneity and disparities has really given me an opportunity to address some issues that we hadn't covered before. So here we go. Move this forward. Yeah, here we go. So the issue is heterogeneity in dementia of the Alzheimer's type, or an Alzheimer's disease. This is a very, very old paper that started off a study that I call the Predictor study. We just were in year 30 of this study, and it's really much longer than that with no cost extensions. It was the first grant I ever had. So I've been involved with it for a very long time. This paper was the set of observations that sparked me to write the grant. My colleague, Richard May, who's the chair of neurology now, this was a long time ago, came to me and said, you know, I've been seeing a lot of patients in the clinic, and I have data. I ask them the same things every time. I get a mini mental, and I get functional information. I get extrapyramidal signs, because we had just seen some papers that extrapyramidal signs were prevalent in Alzheimer's disease, and we get psychiatric stuff. Just put it together, and let's put it together and see what you think. And this graph is from the paper. This was before PCs. We had this thing in the our GCRC was called Clinfo, which was supplied, and it was a computer that we could use to analyze data. Anyway, enough of memory lane. But what I showed here, very, very, very blunt way, not very elegant, is that if you look at this is functional activity, where the higher score is worse. If you look at patients over time, they did show an increase in their functional activity score. But if you divided them up into those with and without extrapyramidal signs, those with extrapyramidal signs actually had much faster progression than those without. And it got me interested in this idea of heterogeneity. We found some other features, like psychiatric features, were also associated with differential course. But this was a convenience sample, and the idea was to create a formal study to look at that. And that's the genesis of the Predictor study. So the Predictor study, as I said, has been going on for a very long time. It started out with what I call the Predictors 1 cohort. We teamed up with Johns Hopkins and Mass General. And all three, Columbia was a coordinating site. Every site tried to recruit people with mild Alzheimer's disease. These were people who came in for clinical evaluations. They had to have relatively mild severity. And the idea was to follow them every 6 months for as long as possible. And in the first Predictors cohort, there were about 236 people like that. And then about 7 or 8 years later, we were making good progress, but I felt like we needed another cohort to validate observations in. So we started all over again with Predictors 2 cohort, again across the same 3 sites. I have to say, when we started this, we didn't know about ApoE yet. There was no treatment for Alzheimer's disease yet. So the Predictors 1 cohort really were not on any kind of official drug. Some were taking part in trials. By the Predictors 2, almost everybody was on Aricept. And so, and then as I was trying to review the Predictors 2 after the first 5 years, I started getting pushback from reviewers that, hey, this is really a clinic-based study. It's not population-based. It's not representative. And so for the next cohort, the Predictors 3 cohort, we decided to go into the community. I've been involved in a very large epidemiologic study of elders in North Manhattan. It's called the Washington Heights, Whitecap over here, Washington Heights Inwood Columbia Aging Project. Richard May is the PI of the study. Over the years, there's been several cohorts of people randomly selected from the community and followed about every 2 years. The focus really was on people who were not demented and following them over time. And a lot of the issues were risk of dementia. But I'd always been interested in the people who became demented in YCAP. For those of you who are familiar with the North Manhattan community, Washington Heights, where our hospital is located, it's a very diverse area. I would say equally divided in YCAP, or more than equal, Black and Hispanic, that we could say Latinx, a smaller minority of white people. So it's quite a diverse community, ethnically, economically. So what I really wanted to do was catch the incident cases that were being followed, that were picked up by this YCAP study, and include them as very mild Alzheimer's disease, and then follow them like I had previously. But it turned out that we were not getting the same rate of incidence that we had seen previously in YCAP. So in the end, we included 115 incident AD cases, some prevalent AD cases, about 50, and then we even included a group of people with MCI. So these are people living in the community. They're not clinic-based. They never came to a doctor specifically to be diagnosed. We diagnosed them as part of our epidemiologic study, and we're following them yearly. And that follow-up is ongoing. For Predictors 1 and 2, follow-up is up to 10, 12 years until death. We're at about 7 years of follow-up in Predictors 3. So the Predictors 3 allows us for, as you'll see, to compare results that we had earlier in a more representative population. So this is a very early paper, not the earliest, but it just gives me an opportunity to introduce some features of the Predictor study. So you can see this is from my colleague, Nick Skarmeus, who was at Columbia at the time. And you see he included Predictors 1, 234 subjects for Predictors 1, 222 subjects from Predictors 2. Note that their education, pretty high, average of 13 years. And you notice that he didn't even bother to put an ethnicity because it's almost all white. Later, this was a long time ago. And what Nick was looking at here was the delusions, hallucinations, and their influence on disease course. So the idea was to look at, here we use time-dependent covariance, but looking at delusions and hallucinations as time-dependent covariance here. And very often in predictors, we use a set of outcomes, time till reaching a cognitive score, a mini mental score, relatively low, a poor function. We have a technique that allows us to see whether people meet criteria for institutionalization for nursing home care, whether or not they have it, and death. And bottom line is we found that both that for the cognitive outcome, even with or without covariates, we found that delusions and hallucinations were associated with our cognitive endpoint and our functional endpoint, although hallucinations seemed to do better after covariates were included. For institutionalization, hallucinations seem to work better after covariates than delusions. And this is something we found most of the time. Usually these variables are not associated with mortality. Although here in this analysis, we did find if you just bunched hallucinations, we had that prediction, although in other analyses we didn't. so just recently, it's just in press. One of the aging fellows decided to try to do the same analysis now in the Predictors 3 cohort. So first things first, the average education in the Predictors cohort was 13 years. Here you see the average is about 7 years. So it's a different cohort. You can see that if you look, there's a total of 23 non-Hispanic whites, very predominantly Hispanic, small smattering of African American. So it's a very different cohort. She tried to follow the analyses that Nick Skarmeus did in the original paper, but the analyses were eventually shaped by the reviewers and what the reviewers wanted to see. So if she just looked at psychotic features in general, again, for the same functional endpoint, she could find good prediction of time till a functional endpoint. She did not find it for the cognitive endpoint, but did find it for heavy duty dependence, which is we have a dependence scale, which is what we use as a proxy for need for a high level of care. And so she pretty much replicated what we found it when she broke it up into specific aspects of psychotic features. Hallucinations were predictive of function and need for nursing home care, but agitation was only predictive of the functional outcome, delusions for a function and for need for nursing home care. So, we're starting, this is really the beginning, we're starting to replicate these kinds of basic findings in again, this more culturally diverse population. Here's another early paper. I don't even show you the table from the paper itself because you can't get PDFs from neurology anymore from so far back. And the copy that I have really is not so clear. I just have a Xerox, but the basic idea now, I just want to focus on extrapyramidal signs. Here we looked at a lot of things. So that's another early thing that we saw from that first study I showed you with Richard Mayu. So we looked at our same 4 endpoints now with extrapyramidal signs, and we found that extrapyramidal signs were associated with increased risk of having a low mini-mental, and increased risk of having bad function, increased risk of need for nursing home care, and also for mortality. And we did this both with time-dependent covariates and just covariate at baseline. And here you can see, here's extrapyramidal signs for need for nursing home care, and you can see that the people with who had extrapyramidal signs really did much worse. They reached that endpoint much sooner. And then again, just recently we're replicating, trying to replicate that in our Predictors 3 sample. Again, here you can again see the diversity of the population, here, so far, what we found is that extrapyramidal signs are associated with risk of death, and with our functional endpoint, we're not reaching significance for the cognitive endpoint or for dependency. I think we need to do a little more work because remember, our population now is a mix of incident, prevalent, and even people with MCI. So I think we'll have to dig into it a little further. But you can see the pattern. We're trying to take these findings that we had before and replicate them, at least in the Washingtonites community. I was thinking of this. We started to think of costs very, very early. I'll just give you an example. Here's a very early paper that we published. These were not even linkage costs. We got costs in another way, but we have this scale called the dependence scale, which was was really developed for the Predictors study. It's sort of a unique scale in that it doesn't talk about the problems the patient is having, like the typical ADL scales, can he dress himself? It's more about what the caregiver has to do for the patient. And it turns out to be a very unique scale. It's included in a lot of trials now. And here's just a simple demonstration that as the dependence scale score gets higher, in other words, more dependence, costs begin to increase, both medical and non-medical. Just as an aside, drug companies, when they try to market a drug, have to start to show how the drug will save money and create a cost plan. They have to bring it to NICE, for example, in Europe, and show how many QALYs the drug will reduce. And one drug company was trying to develop a whole model that took advantage of the costs and increasing dependence as a way of modeling the efficacy and the costs associated with a drug. Okay, and then Medicare. So we now have linkage, Medicare, Medicaid linkage on the entire YCAP population, including Predictors 3. And we also have it on the Predictors 2 study. And if Partha is still here, sorry, I'm just calling you by your first name because I can't remember your last name too well. Recently, there's been an amazing program where the NIA is facilitating us getting these linkage costs, these linkage data at no cost. But whereas before we had to write them in as an item in our grant. So I just wanted to acknowledge that. This is an interesting question, and someone raised this a bit yesterday as well. This uses the entire YCAP population. So YCAP is quite large between 1992 and 1999, and there was another cohort later. There were over 5,000 people recruited. We could match a little less than that to the CMS Medicare and Medicaid service numbers. And then we had to limit it to people who were on Medicare, just Medicare without Medicaid. We've looked at people with Medicaid separately or the combination, and not on a plan, not on, they're on full Medicare fee-for-service plans. And then eventually we ended up with 2,308 people where we had that good overlap, and we worked with, in the end, with a little over 2,000 prevalent and non-dementia subjects included in the analysis file. Now, what's really cool about this is that we see these people in YCAP and they're all diagnosed. They're diagnosed by the study, using a neuropsychological evaluation and a neurological evaluation, really very much what would happen in a doctor's office. But in real life, we are not involved with their diagnosis. So what we were interested in is the disparity between how we were carrying these patients in the study based on our clinical diagnosis and what we could get out of the Medicare claims. And we had up to 10 years of claims on a lot of these people. And it's a little scary, I think. These are people that in the Medicare claims had a clinical diagnosis of dementia. Let me see if I get it right. The claim, yeah, no, we gave these people a clinical diagnosis of dementia. I'm sorry, and out of about 500, only half of them had a claim in the Medicare, Medicaid that was associated with dementia. This was, looking very, very closely over many years. So about half of them were false negatives. So we were carrying, as far as we're concerned, we were carrying them. We had diagnosed them as being demented based on our clinical eval, but there was no evidence of that in Medicare. And then we could look at the other side. These are people we carried as not demented. And most of those, the great majority, didn't have evidence of dementia in their Medicare, Medicaid claims. I'm sorry, in their Medicare claims. But about 136 were carried as demented, even though in our hands they were not. I think this part is the more shocking because people really do use claims data to look at prevalence of the disease, look at costs associated with the disease, look at costs prior to onset, et cetera. But we are in a relatively unique situation where we had a true direct evaluation, and it was the claims were missing about half of the people that we had diagnosed. What was unique about the people that where there were errors? They were more likely. One thing is they were more likely to have the people that got a false claim of being demented were more likely to have higher, more problems with their function, and were more likely to have some encounter with skilled nursing home facility. Yeah, I think, and the cognition, we had some people with lower cognition ended up being called demented by the doctors via the claims, but not by us. So those were, I think, the three things that we picked out. And the costs are very interesting. So here's clinical diagnosis, non-clinical. So here is the true positives. Here's some adjusted annual expenditure, about $18,000. And these are the true negatives. How about the lowest cost, $8,000? The false positives had the same costs as the true positives. So these were obviously people that had some difficult medical issues, but perhaps that's sort of what led to them being called demented by their clinicians. Yeah, and you can see that these false negatives, these are people that got a diagnosis of dementia. I'm sorry, these are people that we called, they have diagnosis of dementia, but were not caught by the clinicians. They were not on the Medicare. They were lower. They didn't get as much in terms of costs. So I think this has implications more than we can get into here for how people are identified in these claims, and then what the diagnosis of dementia does in terms of costs. Is it true? Is the reason that these people had as many costs is because they were identified as being demented, or they identified as being demented because they really had other problems that required that additional amount of money? So I just thought I'd throw that in because we had those discussions of Medicare, Medicaid costs. And again, this is in the North Manhattan community. It's different. We certainly have a lot of people on Medicaid in the North Manhattan community. It is, as you saw the ethnic distribution. How applicable is our finding to other studies? We did look at other studies. There's not very many where people were diagnosed independently of what you could get out of the claims. There is a high degree of misdiagnosis, but maybe ours is a little higher than because of the nature of the population. Okay. I was very proud of myself when the predictor study started after about 5 years, because we were finding that things like presence of extrapyramidal signs, psychotic features, there were a few other issues that seemed to be associated with poorer course. And I put into competitive renewal to continue to follow the cohort, and the reviewers came back and said, no, you said that you were going to try to find a prediction algorithm. You were trying to predict, and you're just looking at risk factors. You're really not predicting. So our first try at creating a prediction algorithm, and I believe I presented this last time I spoke to you, was pretty straightforward for the time. So for example, here's for mortality. We did a Cox analysis and found the top features associated with increased risk of mortality or protective effects. And then what we did is someone taught me this, I didn't know it then, you can get a weighted average of these of the covariates, weight them by their beta. So here we said, is it yes or no? Here's the weights by the betas added up. And then we could give people a table where given that index, so this is the predictions for mortality. We had stratified the analysis. So if someone's death index was 2.2, they had a 50% chance of reaching that mortality endpoint in 72 months. If the worse it was, if their index was 0.2, 36 months. So it was really the first time that I know of where we could make those predictions. It was published in JAMA. It's included in sort of some of the more well-known algorithms that the industry uses in order to make these predictions of time till endpoints for costing, for like, so I could say this algorithm was included when Aricept went to NICE to be registered in Europe as a drug in their pharmaceutical, and this was the exact algorithm that the company used in order to show that it was saving money, it was keeping people out of nursing homes, and it was keeping people from dying as fast. And then we did validate this in a separate population. And that's where I stood for a while until by a happy coincidence, I met Eric Stallard, who's one of the organizers of this meeting. He chaired yesterday morning. And we were thrown together actually by a drug company. And they asked me to work with Eric to try to apply a longitudinal grade of membership model that he had developed to our data. And Eric took a look at the predictors data and the fact that we had patients followed every 6 months for a long period of time. And he said, no, I want to start over and create a new model. And we've been through this process a few times. So originally a model was created with Predictors 1 data. But the Predictors 2 data is, I think, more representative. We have ApoE on them. We didn't have that from the beginning in the Predictors 1. So a second model is based on the Predictors 2, and that's this model that was published in Alzheimer's Research and Therapy. And the idea is that it includes a lot of the features that we're talking about. It does include ApoE status, which we did not have originally, sex, age at intake, race, and all of those. Then it includes all sorts of indicators of behavior. Here's wandering and outbursts and threats, but also delusions, hallucinations, and illusions. We have a mini mental, we have function, we have dependence, a medical questionnaire, alcohol. Because motor symptoms were so telling in our earlier analyses, it includes extrapyramidal signs, both generally and specific. And it includes a few features that could be associated with dementia with Lewy bodies. So overall, there's 73 variables that could change over time and 6 sort of fixed intervals. I won't go into great detail about the GOM model. I'm bringing Coles to Newcastle for those at Duke. But it's a latent variable approach. It's one that I never had heard of before. So basically, given all of those variables you see, any patient at any time can be their clinical status based on those variables can be summarized by a set of 4 grade of membership scores. Here's a real table of real patients. And the neat thing is it's a grade of membership. So everybody is some combination of subtypes 1, 2, 3, and 4, and it always adds up to 100%. So here's someone who's primarily type 1, although they are type 2 and type 3. Here's someone who's he's 82% type 1, but he's 17% type 3. Here's someone down here who's mainly type 3, but a little bit type 1. And if you think about it, like it puts these people in this space. Here's type 1, 2, 3, and 4. And it puts these people in the space where 4 is the most severe. And then the algorithm also, the model also can model change over time based on transitions for every 6 months. And people change in their GOM score over time and slowly float down till type 4. The GOM status at any point in time can in turn be switched back and be used to predict clinical features. So I just give you so here's, I pulled this out of a table. So let's just take physical threats. So what this, let me pick a good one. Yeah, so someone really making physical threats, if you're a pure type 1, the odds of that happening is 0. If it's pure type 2, the odds of it happening is 0. If you're pure type 3, the odds of that happening is 0.1, and pure type 4, 0.05. And we can do that for cognition also. So here's just orientation. So you notice everything is dichotomized. So this is over 6 or not. So the people of pure type 1 are likely to have pretty good orientation, pure type 2 less, pure type 3 less. And so it's a very unique way of characterizing the disease in its heterogeneity and making predictions. And so just recently, we just had a paper accepted where we took this new predictors model that was generated from the Predictors 2 data and applied it to Predictors 1. You know, so what we can do is we have that full model, we can take the baseline data from Predictors 1 and see how well that model does in predicting time until. Here we're talking about time until death. And because we had created this Cox model before, Eric recreated those Cox models so we could compare how the Cox model does to the longitudinal rate of membership model. And so here's the overall curve for mortality. The black line is actual mortality curves. The red line is the Cox model, and the blue line is the GOM. And then the green lines on the outside are confidence intervals. And you can see that overall, both the Cox model and the GOM model fall nicely within these, within the confidence intervals. In other words, they're making pretty good prediction of mortality. And then here it is by quartile, by quintile, I'm sorry, where we've divided up risk in quintile from the least people with the least risk of mortality to the people with the most risk of mortality. And again, both the Cox and the GOM predictions fall nicely within the confidence intervals. I was a little surprised that the Cox was doing so well, but Eric reminded me that the Cox is specifically designed to make that calculation and does a lot of manipulations in order to do it, whereas the GOM model can make is a generic model of the disease that actually can make a prediction about any feature. So it's really only uses a very small number of parameters specifically to make a decision about mortality. And then we did the same thing for need for a high level of care. And again, prediction was quite good, both with the Cox model and with the GOM model. Again, this was a very specific Cox model design just for need for a high level of care, whereas the GOM model, it's the same model no matter what we're going to predict. And I'll tell you, the model is a complex. It's sort of hard to understand, and we sort of racked our brains to figure out a good way to show people the power of it. Here's what we thought about, and Eric created these figures, and I'll just take a minute or two to explain them to you. So what you have here is a pure type 1, a pure type 2, and a pure type 3. So these are people at baseline that were either 100% pure type 1, 100% pure type 2, 100% pure type 3. And at first we could sort of just look at how they look at baseline. And you can see here's all these different features of the disease. So here's a mini mental score. This is a modified mental that we use between 30 and 57. So it's a high score in the mini mental. So you see the blue line is very high here in subtype 1. In subtype 2, it's pretty high even at the start. By pure type 3, it's already a little lower. So here's a good one, I think, needs to be watched when awake. Let's see if I can, yeah, so here you can see that the pure type 3 already needs a large percentage of those people, they're more advanced, need to be watched when awake, while the pure type 1 and pure type 2, that's really quite rare, etc. So it's really segregating these people at baseline, but it's also giving us the trajectory, predicted trajectory from the model of how these features change over time depending on where they started. Let's talk about marginal mortality. So you can see the mortality curve for predictors 1. I'm sorry, for pure type 1. You can see it's steeper for pure type 3 and intermediate for pure type 2. I mean, one thing that's interesting that we noticed is that this pure type 2 seems to has something about it that even though it's more mild at baseline, a lot of things happen much more quickly than pure type 3, including mortality, including need for nursing home care. It's really a radical increase in need for nursing home care, even compared to pure type 3. And you know, I could sit and stare at this, but what it really does is it gives you an idea of how this model really is coordinating and dealing with the multiple features of the disease and can make predictions about them across time. And we've just begun to forward apply this now to the Predictors 3 cohort. That's again the community-based cohort. These are very rough, but in terms of and actually they might be modified slightly. We're just tweaking the data a little, but in terms of here's survival, actual versus predicted. Here's need for nursing home care, actual versus predicted. Here's the confidence intervals around it. And the model is doing, again, quite well in this community-based, ethnically diverse population. So I think that we have more to do, and I'll just give you an idea of what we're thinking about. We were talking about genetics today. So the heterogeneity of Alzheimer's disease, and we've had a lot of people talking about that. It's most likely due to the fact that, first of all, there's a huge amount of heterogeneity in the underlying pathology of the disease, in the underlying genetics. There's so many other causes besides the plaques and the tangles and the known pathology, as people have discussed. What is to use this heterogeneity that's captured by the model and see how that relates to genetics on the one hand, and how it relates to biomarkers. So we can forward it. So the genetics is straightforward. We have GWAS on these people, and we can try to understand the relationship between these modeled GOM scores and the genetics. For AD biomarkers, we are in the process of forward applying this model to the ADNI data, where they have FDG PET and they have CSF beta and tau and a lot of brain measures. But another really interesting thing is that from Predictors 1 and Predictors 2, we have over 100 brains that had been autopsied just to confirm a diagnosis. But we're in the midst of working with pathologists to say, wow, if you could recharacterize these brains up the wazoo, what would you look at? And can we relate, let's say, GOM status at baseline, that heterogeneity at baseline, to heterogeneity in the underlying pathology? Something that we've been thinking about is, you know, clinical trials right now depend on differential rates of decline as a function of whether you're on drug or placebo. The GOM algorithm is telling us that you can have two groups that look relatively the same at baseline as type 1 and type 2, for example, look relatively the same at baseline, based on their mini-mental, absence, base absence of delusions, etc. But one of them has a much milder course than the other. So there's really heterogeneity that the GOM model picks up. So could the GOM be used to help randomize trials, interpret trials, and then finally develop and support publicly available software for calculation and application of the model to individual patients? The truth is that we really have software like that. With R, Eric and his crew could take the algorithm and turn it into an R program where people could input the same variables that we have and get a prediction. It's very cool. I've been a little loath to make it public yet because I feel that we need to validate it more. And we need to do a lot of crosswalking. So the variables that go into the model are the variables from the predictor study. So we use the Columbia University scale for psychopathology and Alzheimer's disease. Most trials and doctors today use the NPI, which is a psychiatric inventory. Same thing, there's a lot of different functional scales that are used. So I think for this to be useful, it needs real validation and needs to be crosswalked. But the technology is there, and those are the kinds of goals that we have in the future. So I'll stop there. Thank you very much for inviting me, and I'm glad to, if you still have the patience for more discussion, I'm glad to talk about this some more. Thank you, everyone.
Wonderful. Thank you so much, Dr. Stern. That was really exciting. And we're going to just open it up for any questions that anyone might have for you. I'm going to ask Igor to come and receive those questions, if you will, and then give us the final wrap up for the workshop. So,
Yaakov, what would be your message to other researchers, maybe to our younger researchers who would like to work in this area of research?
I think the opportunity now is so much greater. I mean, look what we heard about today, large data sets available. I started out I'm a cognitive, most people don't ask me to talk about this stuff. Most of what I talk about is cognitive reserve and cognition and aging. And I used to start out by doing experiments, and I would meet with epidemiologists, and they say, oh, I'm working with a very interesting data set. And I found that sort of funny because I was doing experiments. I would do 25 young and 25 old, but now there's huge populations to work with. The statistics are, and the programs to do statistics are so well honed. So I think people really have to choose where they're going to sink in, and they can sink in very deep and they can do it very fast. So I think that the opportunity is much different now. You don't have to collect your own data really. There's these, and you probably shouldn't sometimes because these data sets are there. But I think that the other thing is that Alzheimer's disease, as I think people have made very clear, is a very complicated disease, multiple causes, probably multiple pathologic causes, multiple life influences. So there's really, and we really haven't licked it. So there's really a lot of room for some new, interesting ideas, and someone fresh and new might have one.
Thank you.
Yeah.